Now we're on to chapter 30 in your text that covers a mixed group of antibiotics or anti-infectives, macrolides, tetracyclines, aminoglycosides, and fluoroquinolones. Don't let those names scare you. I'm going to try to break it down to make it easy to remember. Remember, each of these is very small chapters, and I'm going to cover one at a time. The first group are the macrolides. Sometimes, or initially, they're referred to as the penicillin substitutes. They will be used when somebody has an allergy to penicillin. They are a broad spectrum. They have large ring lactones, which cause an inhibition of protein biosynthesis. That's how they work. They are bacteriostatic at low doses. That means they inhibit the growth of bacteria. And at higher doses, they are bactericidal, which kills the bacteria. But there's more adverse reactions when you go to the higher doses. The route of administration, it can be given IV or PO or orally and enteral. It cannot be given intramuscularly because it is corrosive. So when it is given intravenously, it has to be well diluted, given very slowly. Watch for phlebitis. If you haven't covered that, phlebitis is an inflammation in the vein. It's painful. You'll see red and streaking as you're pushing the drug in or infusing the drug, and you'll have to stop it. Again, with the route of administration, the gastric acids will destroy the erythromycin, a very common oral macrolide that is given. So they have added this acid-resistant salts to the erythromycin tablet or solution because it can be given in a liquid. Anyway, so this helps it get through those acids in the stomach and absorbed in the intestines. There are some resistant organisms, so these macrolides are used for mild to moderate infections, respiratory, sinus, GI tract, skin, soft tissue, diphtheria, impetigo, and some sexually transmitted infections. Most of them, majority, they are all going to end in the generic name mycins. As we'll get along a couple of classes later, there are some aminoglycosides that end in the MYCIN or MICIN. All macrolides end in MYCIN. Erythromycin is the drug of choice for Mycoplasma pneumonia and Legionnaire's disease, both. That's an infection in the lungs also. The macrolides are excreted in the bile, feces, and urine. So with it coming out in the urine, you want to check for renal insufficiency because that would be a contraindication where you cannot give it. Conjunctivitis is a common side effect to watch for. If they develop a conjunctivitis while taking it, they should not wear their contact lenses, so that is a teaching moment. It can cause hepatotoxicity, damage to the liver that may or may not be reversible when it's given in higher doses. So that is again where I talked about lower doses okay, higher doses more problems. It should never be given with clindamycin or lincomycin. They bind to the same receptor sites, and down here where I have lincosamides, those are the lincomycin and clindamycin. So they're very closely related, and on how they work and where, so they're in like a subclass of the macrolides. So that's why you would not give them at the same time. Some more teaching and things to look for. They will interfere with the serum levels of theophylline, and I think I mentioned theophylline on a previous lecture. Many things interact with it, so it's not used as often. And like many drugs, they can interfere or increase the serum levels of several anticonvulsants and the anticoagulant warfarin. Those are very common. So a lot of times if you see a test question and it gives you a choice of an anticonvulsant or warfarin, theophylline on it with interactions, those most likely are ones that increase the effects. Antacids should not be given at the same time because it reduces the peak level of this drug. Some things were key: sudden cardiac death when it's given with certain medicines like clarithromycin, diltiazem. The common side effects: nausea, diarrhea, abdominal discomfort. If you think of it being absorbed in the gut, it can be irritating there. And as you'll see on almost all the antibiotics, there's a lot of GI issues. So you have a table 30-1 that goes over the macrolide section. It talks about the upper and lower respiratory, skin, and soft tissue. Also, Helicobacter pylori, which I'm sure you haven't covered yet. You'll often hear it referred to as H. pylori. H. pylori is a bacteria that can cause ulcers. Just because you have ulcers doesn't mean you have H. pylori. Just because you have H. pylori bacteria doesn't mean you have ulcers. But it is a bacteria that can result in ulcers. So this is one of the medications, azithromycin and clarithromycin, that can be used for it. Now I want you to note, I did not say it on the previous lecture, always look at the pregnancy category of all these medicines. As you see here on your chart, some of them are B's, but the erythromycin, clarithromycin are category C. In your text, there is a chart, table 12.4, that's in chapter 12, page 130 of the 8th edition. It gives you the categories for pregnancy. It was on, I think, the last test. I didn't stress enough. That is something you need to be familiar with. Don't memorize their category, but know what the category means. So if you're given the category, pregnancy category, you know what that means to you. Category A, no problem. Category B, in animals, they didn't show any problem, but they don't have enough studies in humans. In C, there are some animal studies that show some risk. We don't have the studies in humans. And category C is where benefit outweighs risk, or risk outweighs benefit. Choosing to give it or not depending on how much benefit versus how much risk is it to the pregnant woman and the fetus. Category D, the risk is great. It is proven in humans. You're only going to give it if it's life-threatening. If it's category X, you are never, ever, ever under any circumstance to give it. So when you're given medicines, if somebody is pregnant, childbearing age, potential to be pregnant while they're on the medicine, you want to discuss the pregnancy category with them. Don't assume it's always the provider's job. You are just as liable and responsible as the person prescribed it if you're administering it. So if you notice here, there's a category C and the rest are category B's. A very, very other common one of the macrolides is erythromycin. Erythromycin is very upsetting in the gut. It's the one that they put the salts in to absorb later. So some people won't be allergic to it, but they're intolerant in taking it orally, where it makes them vomit. So you might see that. These lymphocytes mentioned briefly there. I'm not going to go into a lot. I want you to glance over it in your text. They are bacteriostatic and bactericidal, the same. Staph aureus, active against most gram-positives, against Staph aureus and some anaerobics, but not against the positives. Lincomycin I've used just a few times in my cure. You really don't see it. It has a short half-life, isn't real effective on a lot of things, has too many toxic effects. So clindamycin you will see used. GI irritation is huge. Colitis is mentioned in your text. When you think of clindamycin, think of colitis and inflammation of the colon. I have seen people with severe cramping, diarrhea, to the point of being dehydrated with taking clindamycin. It can be very, very irritable to the stomach. Stomatitis is the sores in the mouth, which can be common too. So what I did here, this is showing you the effect inhibiting the protein biosynthesis for how it works here. I did the gut on purpose to realize here's your stomach, your duodenum, your colon, to understand the big effects here. This here is a picture of Red Man syndrome. Red Man syndrome is also Stevens-Johnson syndrome, a very, very severe, life-threatening, can be life-threatening reaction. Starts with that redness and the peeling of the skin and can become more significant. Make sure you look at your nursing process. It covers on the macrolides here, on what you're monitoring, looking for the liver, administering antacids either 2 hours before or after, about diluting it when it's IV. It gives you some excellent tips in there. Super infection, because there are resistance, stomatitis, vaginitis may occur. Talking about having the patient report loose stools, diarrhea, because of that pseudomembranous colitis, where the membrane really gets inflamed in the gut, and it can lead to a secondary infection like Clostridium difficile or C. diff, which you've probably heard about that at some point. The last thing under this category, did I not put them on here? Glycopeptides. I don't know why I didn't put them there. Anyway, it should have been in here. So the glycopeptides, the vancomycin. Vancomycin, if you've not seen it given, it is always given IV. It treats the drug-resistant Staph aureus like MRSA. You have to monitor the vancomycin levels. It can be given orally for enterocolitis and that antibiotic associated pseudomembranitis. That might be from some other macrolides. This one, this glycopeptide vancomycin, is given to treat that. When it's given orally, it is not absorbed systemically, and it just excreted in the feces. So that's why it treats that pseudomembranous colitis when it's given orally. IV is when they have a severe MRSA methicillin-resistant Staph aureus that is not responding. Unfortunately, there are vancomycin-resistant enterococcus, or VRE, that is now becoming more and more prevalent, and I think I mentioned it on the previous lecture. Side effects: nephrotoxicity and ototoxicity. The hearing damage can be permanent. There can be a loss of balance, temporary or permanent. And nephrotoxicity, watching the kidney function, not giving it if there's a kidney function. Your text talks a little more about that Red Man syndrome, hypotension, tachycardia. Let me see, anything on the ketolides, structurally related to macrolides, the visual disturbance. I have actually never given telithromycin, so I'm going to skip over that one and move on to the next one here. Your next section of your textbook goes over tetracyclines. Now, your tetracyclines were the first broad spectrum effective against gram-negative and gram-positive organisms. Now your text talks specifically about some which may not seem important to you, so I'm going to explain it to understand the significance and when you would see some of these medications ordered. So it mentions mycobacteria. Mycobacterium is the bacteria for TB or tuberculosis and leprosy. Leprosy you will see in other countries. I don't know that that there are cases in the United States itself, but you will see tuberculosis or mycobacterium, and that is one of the things that this group, the tetracyclines, are effective against. And rickettsia, that is the one that causes Rocky Mountain spotty fever that can come from a tick bite. Spirochetes is the bacterium or organism, not bacterium, the organism you will see in both syphilis and Lyme's disease. And if you don't know, Lyme's disease is another infection that can come from a tick bite, and the last is chlamydia. So if you see right here the spirochetes of syphilis and chlamydia, you will remember that tetracyclines can be used for sexually transmitted infections. It too inhibits protein synthesis. It's bacteriostatic, not bactericidal. I wrote the cyclines on the bottom of it because all of them will end in that cycline ending. I put a picture here with two cuties say no to OBs. So there's two drugs, and the quinolones and the tetracyclines that you never ever give in pregnancy. If you look at your chart over on table 30-2 on page 421, you will see that they are all category D. And if you remember category D, there is proven problem. They only give it if there's a life-threatening infection, that this is the only choice they have. The route of administration. Orally can be given. I did the picture of the teeth here because it can cause staining of the teeth when it's given in that oral route or to the very young. I grew up with somebody that had tetracycline as a child, and we were teenagers, and that's exactly what her teeth looked like from having received that at a young age. Of course, was way back in the 70s, and we didn't know those things then. Tetracycline can also be used to treat Helicobacter pylori or H. pylori that I mentioned. It is a common drug given for acne, but it's given in very, very low continuous doses for chronic acne to minimize the side effects or the toxic effects. They've been around a long time and used so much that there are a lot of resistance occurring with them, and also like gonorrheal infections. So it can cover the syphilis and the chlamydia, and chlamydia and gonorrhea often go together, so you'll need a second antibiotic to treat the gonorrhea because it is no longer effective against that because of the amount of use. I mentioned the teeth and problems, so it's usually given IM or IV, usually IM, because the IV can be very, very irritating. So the oral preparations that you will see now is really the doxycycline oral. It's rapidly absorbed, completely absorbed. You cannot take them with magnesium, aluminum, antacids, calcium, or iron-containing drugs because they bind with the tetracycline and they prevent the tetracycline from being absorbed and doing any work. Because of the because of the absorption issues, they say to take it on an empty stomach except for doxycycline. And I'm telling you right now, the only oral you'll really see out there is the doxycycline, and you don't have to worry about an empty stomach. Big side effect with the tetracyclines is Photosensitivity. I could not come up with that word, photosensitivity, which I mentioned in some previous lectures, how significant a photosensitivity can be. They're used, doxycycline is used quite a bit, but there are side effects, toxicities, drug interactions, and as your text mentions, the GI, which I talked about, photosensitivity, the problems taking them during pregnancy, before age 8, the staining of the teeth, but you don't give it during pregnancy. Nephrotoxicity in the higher doses, the secondary superinfections that can happen. There are several drug interactions. Not give it with a penicillin because it decreases the effects of the tetracycline. So it's something to keep in mind when you're being treated with 2 antibiotics for sexually transmitted infections. And administering tetracycline with aminoglycoside increases the risk for nephrotoxicity. So kind of look over your list there on tetracyclines, and briefly going to mention the glycyclines. See, I can't even say it. It's tigecycline, a synthetic analog of tetracycline. It blocks protein synthesis for complicated and intra-abdominal infections. It's only given IV. Everything about it is similar to the side effects and reactions from tetracycline. Enough on that one. We're going to move on to the aminoglycosides. And believe it or not, we're almost done with this chapter. So the aminoglycosides, they are broad spectrum. Not broad spectrum. Their spectrum is for gram negatives. They inhibit bacterial protein synthesis. They are often used to treat also tuberculosis. Unfortunately, there is bacterial resistance. There's that ototoxicity again, which you'll see on a lot of this whole class of medicines. Streptomycin is a drug of choice to treat bubonic pneumonia plagues, which we don't really see in this country, thank goodness. They cannot be absorbed from the GI tract. They do not cross the cerebrospinal fluid, the blood-brain barrier, except in children, but it can in adults. They do in children, not in adults. Why would that be important when you're thinking of infections like a meningitis, something that is actually in the brain, or an encephalitis in the brain? Primarily given IM or IV. It is never given. Neomycin. Not given orally. It mentions neomycin. But neomycin is one of those ones now that you really will see in a topical solution or ointment. I don't know that I've ever really given it IV. It says it's given pre-op bowel antiseptic, but I'm not sure that I've ever given it. Anyway, so aminoglycoside currently used for Pseudomonas is gentamicin, tobramycin, and amikacin. Gentamicin is one of those ones to remember. You always think gentamicin, think aminoglycoside, think drug levels, peaks and troughs, looking for half-lives, watching kidney function. Those are big when it comes to the aminoglycosides and gentamicin. The ototoxicity, nephrotoxicity are the two main things looking for this. And also gentamicin has a very, very short half-life. So what's that mean? You end up giving it 3 and 4 times a day. And it cannot be given orally, so they're either getting shots or they're having to, usually in the hospital, getting it IV. I put this picture here for how it works, with inhibiting protein synthesis. And then I thought this was a really good picture aminoglycoside toxicity because it's ototoxicity, nephrotoxicity. So if you can see those two little pictures in your head to help you remember. Table 30-3 on page 423 in your text goes over some of the aminoglycosides. Gentamicin is the biggest of those, or streptomycin, but mostly gentamicin is a big, and if you look down your list for pregnancy category, your gentamicin is a category D, and your streptomycin is a category D, which is not good. Okay, look over your nursing process for aminoglycosides, giving you tips to remember and what to teach, what to look for, what to tell the patient, what they need to report to you. And at the bottom here, cultural considerations: do not give directions such as take one blue pill at specified time. Provide the name and dose of the medicine in the language spoken. There are all kinds of materials you can print off now. A lot of hospitals will have it where you can do in other languages, and a lot of hospitals have a person, usually it's Spanish. Sometimes they have other translators in the building. If not, they're required to have access to things in a patient's language, so they'll have language lines that you can access. I'm not sure how many language lines there are in some of these rural areas because I've not worked physically in the rural hospitals. I know in the clinic settings in the rural areas, what I have done is you can go into Google. There's Google Language, Google Translate, which is awesome. If that person can read in their own language, you go in and you type it in English and select it to translate to their language, and they can read it and they can type back, and I've used that to communicate before. Okay, here we go. The last class in this chapter, the fluoroquinolones. So what do you need to know about them? They are broad spectrum positive and negative organisms. I thought this was a good picture here. It's just bright and it tells you about inhibiting the DNA synthesis again. It is given only orally and IV. It is not given intramuscularly. It is too painful. It does need a lot of dilution when given, and it gives you all these directions in here how to dilute it, but I'm not going to go there. It's recommended not to be taken with food, but it doesn't impede it. It just slows down. So if it's really bothering them, they can take it with food. It just slows down the absorption, but does not impede it or block it. When you think of fluoroquinolones, I put on here fluoxetine because they do all end in the fluoxetine. My thing is the F for fluoroquinolone in fluoxetine. That's how I remember them. Of course, we have a million brand names, but ciprofloxacin, most females out there probably are familiar. Well, maybe not. You guys are young, but Cipro. If you get older, you'll have a UTI sometime in your life that's going to be treated with ciprofloxacin. So it is a fluoroquinolone, and as I said, it's treating urinary infections. Urinary tract infections, very common. Even levofloxacin is used for more things outside of just that. So levofloxacin, primarily for respiratory infections such as community-acquired pneumonia, chronic bronchitis, acute sinusitis, and also can be for severe urinary tract infections, sometimes certain kind of skin infections. A newer one, moxifloxacin, which you may have heard of as Avalox, is neat because it's a once-a-day dosing. Some of these medicines, like levofloxacin, different ones, zithromycin, people will call a Z-Pak, and you'll see that you take it for 5 days or you take it for 3 days. That's because something like that, they have a very, very, very long half-life. If you look at some of these, having a half-life of 36 hours. That's why you can take it for 5 days. The antibiotic is still working for several more days after the last dose because the half-life is so long. So that's a teaching thing. People will take a medicine, an antibiotic for 3 days, but I'm not feeling better. Teaching them, you take it, the antibiotic is still working for several more days in your body, even though you're not physically taking it, it's still fighting that infection. Also, if there's an interaction and something they can't take with it, because that antibiotic is still working in the body, you have that extended period of time they still can't take other things that might increase, like your interactions with anticoagulants like warfarin or seizure drugs, things like that. Anyway, I just thought I'd throw that in there. Let me get back to here. In your, let's see, fluoroquinolones, table 30-4 on page 425, you'll notice it's only PO or IV, and that they are category C. There's a few Bs, most of them are Cs, the ones you're going to give, like ciprofloxacin, levofloxacin, moxifloxacin. Those are the ones you will see the most in your practice. Remember, all of these coming through the kidneys, so you're checking for renal function, you're going over their diet history, and in your nursing process section, it tells you when levofloxacin is taken with a non-steroidal NSAID, central nervous system reactions, including seizures, may occur. Many people will take ibuprofen over the counter. So that is, Advil, things like that, or naproxen. Those are all non-steroidals. Even aspirin is a non-steroidal, so that is a major teaching to do when somebody is on levofloxacin, because they will take that as an oral medicine at home for a few days. And then I put the lipopeptides, which is on page 427. Daptomycin, I have seen that's one that you will, it's bacterial cell death, used for really significant MRSA, infective endocarditis, septicemia. You will see that in the hospital because it's given IV, it needs a lot of dilution, primarily excreted in the kidneys. It is a pregnancy category B, but it has to watch your kidney function because that is how it's excreted. Some serious side effects, the most serious are chest pain, see hypokalemia, hyperkalemia, it's affecting the sugar high or low, the potassium high or low, rhabdomyolysis, which is a huge infection that damages all your muscles, start to die. That's a very threatening. And notice again in drug interactions, warfarin may lead to increased bleeding, okay. And that is the end of my review of this chapter. I'm going to show you the very last slide. I found this online. I thought it might help some of you, a little quick reminder of things you're looking for with this class of medications. And that completes my review of chapter 30.